of things.
I'm just starting the recording, just record this session, okay? So unfortunately, there's no one else here, but anyway, I think we'll just, I think if you've studied, then you know, but I think it was just for people who have no idea. It is just to give some idea of what the questions are, okay? Because metabolic medicine, as you know, people generally tend to avoid. At least I used to avoid it, yeah? But the interesting thing is in the exam, what we found is that they carry, which I was very surprised to learn later on, that carries more marks than other questions. So there are certain topics which have more weightage. All right. So
Is
say
it
so
so?
all,
Like,
yes.
in
Not all are
okay.
marked equally. Not all questions are marked equally,
Oh,
which I didn't know.
okay.
It is written in subtype. It is obvious they have got an average mark, but generally certain questions like cardiology, metabolic medicine, and I can't remember what else. There are few things which have more weightage, which carry because, and that's
Okay.
why you cannot miss them. Like even statistics, like you cannot sort of, you need to get it right really. Okay,
So
so
more weightage in the terms of number of questions, or maybe
marks,
the same question, there'll be more marks.
there'll be more
Which
marks
is
as
it?
far as I remember, but in more marks in whatever sense. Okay, whether it's more questions or more weightage, I can't remember exactly, but basically it is more weightage. It has got more value basically. So you cannot avoid, you cannot ignore. Okay, so that is the thing about metabolic medicine. Now, metabolic medicine by itself is huge, and there's lots and lots. It is quite challenging if you look at it. But for MRCPCH, I think if you've gone through the papers, there are few things which they ask. Okay, there are certain things which they will question on. They'll ask questions on, and I think if you have the right strategy and you know that where the questions are going, then you can reasonably, I would say it is a probably a good place to score marks if you have an orientation that these are the type of questions which are coming. Okay, so what I'll do, will not take too long. I've just done a very few random questions. Okay, just to recollect. They are not very difficult questions, but it's just to highlight that whether we are aware of the type of questions. So I'll just try to do this, bring it up. Mm, 1 second. One second, let me just do the share screen. Okay. All right, so we'll start. As I said, today is I put it very briefly just to give a running idea what type of question comes. So let's go through this one. All right. See what you think of it. Tanush, you are well prepared because you've gone through the stuff. So just tell me about your thinking process. Go through the question. And if you know it, then it's okay. If you don't know it, then it's struggling with it. It's one of those things. If you know, it's very easy because these keep coming in the question again and again and again and again. Again and again, keep coming. So just unmute yourself and just tell us your thoughts. Just think aloud.
Okay, a 2-month-old
What you
baby
think?
is admitted with
Hmm.
seizures and failure to thrive. Following a seizure, is found to have a blood glucose of 1.2 millimoles per liter. Other biochemistry reveals a lactic acidosis and hyperlipidemia.
Hmm.
Okay, examinations reveals hepatomegaly with palpable kidney. Okay, what is the most likely diagnosis? 2-month-old seizures, failure to thrive. Following seizure.
So what is the problem basically? Why is he having the seizures? The 2-month-old baby. What's the cause of the seizures? You can see, isn't it? The normal is the blood sugar normal.
No, it's hypoglycemic, sir.
So that is the issue, isn't
Blood
it?
glucose is less.
Ah.
Yeah,
So, but
but
he's got hepatomegaly and palpable kidneys. and it's got acidosis and
Hypothetically will have
hyperlipidemia.
again
So the lipid
lactic
there is
acidosis and
excess, but the
hyperlipidemia.
glucose he can't, he can't use the glucose. So probably the body is able to store the sugar to glycogen, but probably because he's got hepatomegaly means what? There is glycogen in the liver, but he cannot break down the sugar.
Not able to utilize the glycogen in the
Absolutely.
liver.
So when there is a lot
That
of
is the
money in my bank, but I don't have money for day to day. I can't buy my bread for daily to living. I have a lot of money
yes.
in the bank, but for some reason I cannot break the money for my day to day use. I'm starving to buy stuff in the food,
There's
for
a chance this would be a carbohydrate metabolism defect in
what
which
do you mean by
the glucose
carbohydrate?
is. I
No,
mean, glucose
it's a
is not being
storage
able to
disorder.
be
I've given you a link.
storage disorder.
It's a
Exactly.
storage
Yeah, yeah,
disorder.
storage.
So these are the choices. Now you should have an idea which one is what type. Then only you will know. What is McAdams disease or which category? That's what when I went through it. So even they have done it so many times. Initially you get which one is what?
McArdle's disease is carbohydrate metabolism defect type 5
Are you sure? Okay, and then
uh, a child gets tired after doing some exercises. There's fatigue, and then after stopping, he can. I mean, there is a problem with uh, this is the carbohydrate metabolism defect in like, and then von Gierke is another one. Type 1 is von Gierke, and type 5 is the McArdle muscle phosphorylase enzyme deficiency in McArdle disease. There
oh,
is no seizure in McArdle disease, and this does not present in this age group that has. Von Gierke's disease is again this is type 1 glycogen storage disease is von Gierke, that is glucose 6
okay. I
phosphatase
think
deficiency.
what I'll do because Kaustav has joined. So I'll very briefly. I know Kaustav. Kaustav, hi there.
Hello. Hi,
Hi.
good evening, sir.
Okay.
Good
Very
evening, sir.
quickly. Yeah. I'll just go through this question quickly, and so that you can help Tanushree with the answer. So just go through the question because it is just if you don't know, it's a bit challenging.
Baby is admitted with seizures and failure to thrive following a seizure is found to have blood glucose concentration 1.5 to active acidosis and hypertension.
So this appears
Okay, you've seen that. Kaustav, have you seen?
Yes, sir. Yes, sir.
You want to see the choices or you want to go through it again?
I'll go through it again, sir.
Okay, so go through the question.
Is admitted with seizures and failure to
If Tanushree has got something in her head, I think you have got some idea what it is, what it could be.
this is probably the type 1
What type of disorder is it?
one second.
I gave you a lot of hints.
It's a glycogen storage disease, that is definite. That is most likely type 1 von Gierke's disease.
Yes. How do you come up to it?
So hypoglycemia with hepatomegaly,
Hypoglycemia with
Absolutely.
hepatomegaly.
Absolutely. See, that's why I'm stressing on the way of thinking. Why? So obviously, baby has got hypoglycemia with fits, which is associated with lactic acidosis and hepatomegaly. So this combination is very specific. And this is because this is basically a glycogen storage disorder. As I said, we have got money in the bank, but I don't have money for day-to-day use. So I've got sugar, my liver is full of glycogen, but I can't use the sugar for my, I'm hypoglycemic. I don't have sugar for my day-to-day use. So glycogen is stored both in liver and kidney, causing enlargement. So the question was very specific. See, the question in MRCPCH is no, each word carries there is something to it. Like they say in Agatha Christie detective book, or even if you read a story, if they show a knife in the beginning of the story, then at some point in the story, the knife will have some role in it. So here also they are saying that the hepatomegaly is there and palpable kidneys. Suddenly, why they are seeing palpable kidneys? Because it would, as you can say, they are both the glycogen is stored in liver and kidney, so both are enlarged actually. So first we need to know this is a von Gerke is what type of disorder? Glycogen disorder, storage disorder. And what are the other ones? Because next time you will probably get questions on these other type of questions. And they are what you call McArdle, Gaucher's and Niemann Pick's lipid storage disorders.
Mm.
But now McArdle disease is also a glycogen disorder, but it is a muscle. It affects muscle rather
Muscle,
than
mainly muscle.
that's where the muscles.
Pompe is mainly
Absolutely.
heart.
There
Pompe is
you
mainly heart.
Pompis, yeah, Pompis is mainly heart, rather than liver. As is Pompis disease, Pompis is heart, as you said. But neither of them will you get hypoglycemia. That is the main thing. Hypoglycemia is not a feature. Okay. So that is hypoglycemia is mainly with von Gerke. So that name is we have to be very confident about that fact that because that is where the question comes because that's a risk, life threatening. Okay, so I think that's it. We got through that. So these are the just glycogen storage disorders. Von Gerke's, Pompe, Corey, Anderson, McArdle, and there's something called HERS. McArdle is muscle, so M for muscle, M for muscle. HERS is hepatic glycogen. Anderson is AB, but branching enzyme. Corey is debranching. Pompe is lysosomal. Von Gerke is, I think, I don't know, V for H or something, VG, that's it. Just for remembering it. Now, glycogen disorder, what happens? So normally you have normal level of glycogen in liver, and healthy person, what are you having? Glycogen production is there, also glycogen breakdown is there, both way. So traffic is movement in both directions, up and down. Here, what is happening? Glycogen storage disorder. This is glycogen production is there. You're having so much of sugar, so much sugar is there. Even in the kidney, so much of sugar is there. But in the main road, it is not releasing in the main circulation. So it's all getting stored. It cannot come out. This is reduced. Glycogen breakdown is reduced. Yeah, this is the glycogen store. So I've got money in my bank, lot of money in my bank, but for my day-to-day money in the purse, day-to-day use, this don't no money. I'm going hypoglycemia. Yeah, is that an easy way to remember?
Yes, sir.
Okay. So let's move on to this. Again, von Gerke this actually comes up several times. I've seen several questions come up in the MCQs. If you are doing the MCQs, you should find lots of questions. Autosomal recessive, they will keep asking. Hypoglycemia with lactic acidosis during fasting is a very common scenario. Very common scenario. And large liver, so distant abdomen, something like doll-like faces. This is very much asked in the exam. Doll-like. And sometimes I think you can get the picture of the face also. They will give you some hints. Poor growth, seizures, cholesterol is increased, and triglycerides are increased. And the treatment is important because this is where they use infusion of, whole night they're using glucose, especially at night. Until 2 years of age, they will have to give continuous glucose infusion. And I remember this because I think we had one of these cases when was in the UK. And after 2 years, you have to give cornstarch so that it will slowly release the sugar over a longer period of time. Because the body just is not storing glucose. So you have to make a system where the body is having continuous source of sugar, glucose, slowly all the time. Frequent meals and snacks. Because if you're not giving frequent meals and snacks, the body basically there's no store at all. Allopurinol if uric acid is too high and liver transplant later. So I hope this is a good summary. Yeah. Okay. So I'm having a lot of silence. So I don't know whether you guys are there or not there. Are you listening or not listening?
Yes, sir.
Okay.
Yes, sir.
Yes,
Yes, sir. I was muted.
I need the energy.
Yeah.
Otherwise, my energy levels will go down. My glucose level will go down if you don't give me glucose as well. It is both way, liver and blood. Both has to go both way. Otherwise, I'll feel bored. Okay. So there it is. So this is. I hope you need to remember this really. So and what happens in von Gerke? Sorry, the spelling is wrong. But brain damage, cataracts, that sort of thing. Anyway, just stop this one. Yeah. So brain damage, cataract, jaundice, enlarged liver, kidney damage, galactosis, infant is given milk, sugar builds up, damage to liver. I don't know, is it galactosemia or is it von Gerke given? I don't know if this is maybe it's galactosemia, isn't it? Infant is given
I think
milk.
so, galactosemia. This one is for galactosemia.
This is for galactosemia, actually. It's not for von Gerke. Just sorry. This is for galactosemia. I've written instead of galactosemia, I wrote von Gerke.
For galactosemia.
Yeah, but I thought I'll bring it up here. The reason I brought it because I thought it's very confusing because when they give the question, they're very similar. Yeah, very similar, is it not? So again, you have to know this because it's cataract, jaundice, Again, you're getting enlarged liver. And as I said, you can't give milk, unmetabolized milk sugars build up, and damage the liver, brain, iron. So we galactosemia will go through it again, because that is again very commonly given in the exam. Very common. Galactosemia is a very common question. So, okay, we need to look into
Casein
that.
hydroxylate base needs to be given, sir, in galactosemic patients.
Sorry, yeah.
Casein hydroxylate formulas need to be given in
Yeah,
with
you're absolutely right. You cannot give ordinary.
galactosemia.
Yes, there's special formula, otherwise it
Yeah,
will just cause
yeah,
damage. So that is the treatment part you
yes.
have to
Abbott,
remember. And the question will
yes,
come,
Abbott
MRCP
has come up
question.
with this kind of formulas.
Say that again. Yeah, something about
Abbott has
treatment.
some formulas.
Yeah. So there are special formulas for that. You just can't give normal milk. That is the main thing. So forget about warm. It is basically your galactosemia. Again, lipid storage disorders, just to know, because there was mention about Niemann pack. So what is lipid storage disorders? Which are the types? So just remember the names: Gaucher's, Niemann-Pick, Krabs. These are all the lipid storage. And these sphingomyelin deficiency, beta glucurotinase deficiency, and what do you get? Basically, salient features in Gaucher's are adult, infantile, juvenile. There are so many types. Hepatomegaly, erosion of erosion of bone, moderate anemia. Again, Niemann Pick, you get CNS damage. And see, this is a question which comes very often. Cherry red spot in macula. Believe me, this keeps coming in the exam, isn't it? Where you will get in the picture, especially in AKP, you will get a picture of a cherry red spot in macula. Death occurs by 2 years of age, mental retardation. So this is a hot topic, very hot topic. Krabs leukodystrophy. Again, here is a galactocerebrocyte, severe mental retardation, total absence of myelin. There's something called globuloid bodies in white matter. So these are the ones you need to have some idea what is. Gaucher's again keeps coming in the exam. At least you should have an idea which type of disorder is a
In
lipid
pop
storage.
and test, we do not get those visual questions, sir, media with pictures and all.
Which one? Say that again.
Hello.
Yeah, sorry. Just repeat what you said. Can you hear
Hello.
me? Yeah, can you hear me? I'm audible. Kaustav, I'm audible?
Yes,
Hello.
yes, sir.
I'm audible.
Yes, sir. It
So
was breaking up in
Tanushree,
between. It was,
okay, can you
yeah,
hear me?
yeah.
Sorry,
Yes,
now
sir.
I'll sit nearer. Maybe I was sitting far away, so I
Yeah,
could not hear.
your
Now
voice
it's
is,
clear. Now it's
Now
clear,
it's
sir.
clear. Okay.
yeah, your,
So tell me what you were saying. Yeah.
so just to ask you, in pop and test, we don't get those visual pics and all to identify in pop and test.
No.
Media questions all with the videos and pictures and all that.
I couldn't hear you very well, really, to be honest.
No, she's
But
asking
anyway,
the whether
Pop,
pictures are there for identification in FOP and TAS. Usually they don't give
test.
pictures.
no, you're in AKP. So, but you need to have a
Okay.
good idea. Mainly AKP is lots of pictures. So ultimately, even though it's not there in FOP task, but
Okay.
you should have visual idea, because when you come to it helps you to remember. Number one, I find it's very quick to see. When you see this one glance, you will remember this thing very quick. But ultimately, when you give AKP, everything will fit in. They will give a lot of pictures and a lot of clues with, and you have to instantly act very fast. So it will work. Now, again, this is about phenylketonuria. So I think also we can go through that. It's a pretty common question.
Yes, sir. Which of the following statements regarding ketonuria is correct? Is classically due to deficiency of tyrosine hydroxylase. Mental retardation does not occur if the patient adheres to a phenylalanine-free diet. Serum tyrosine levels are typically low. Inheritance is X-linked recessive. Urinary phenylalanine metabolites are typically high. Which of the following statement is correct? Mitchell does not have this
So you
classical.
need to know about phenylketonuria.
Yes, sir.
Mental retardation does not
If
occur if the patient adheres to
patient adheres to
phenylalanine-free diet.
Okay.
tyrosine, I will go for the number one, tyrosine hydroxylase.
Deficiency.
So
Okay.
Yes, sir.
deficiency neither phenylalanine hydroxylase deficiency होता है in this, not tyrosine hydroxylase.
Okay. And
Phenylketonuria
inheritance,
occurs due to deficiency of
serum
phenylalanine
tyrosine
hydroxylase.
levels are
Tyrosine
low.
levels
Tyrosine
are
levels is more, sir.
tyrosine levels are high.
High,
Ah,
high level.
absolutely.
Not low.
Serum
So not yeah, so
levels are
that is high. And inheritance,
autosomal recessive.
autosomal. And urinary phenylalanine metabolites are high.
This one is true.
No,
No, this one is not true, sir.
not true. So first, this mental retardation does not occur if the patient adheres to phenylalanine-free diet. I think that is the true statement, I think. Oh,
Let's see the answer.
okay. Urinary phenylalanine.
So phenylketonuria is the result of hyperphenylaninemia, autosomal recessive. You got that right. Essential amino acid. Dietary phenol is not utilized for protein synthesis, but is normally degraded via the tyrosine pathway. The failure of this tyrosine pathway causes brain and results in other metabolites, causes brain damage. And deficiency of phenylalanine hydroxylase or cofactor tetrahydrobiopterin causes basically accumulation of phenylalanine in body fluids. Now, usually normal at birth, but although blood phenyl, the levels go up early, few hours, 4 hours after birth, mental retardation is gradual. It's not apparent for a few months. The first few months, you will not know anything. And they're saying 25% of seizures, but over 50% will have abnormal EEG. Now, some of the features we know: microcephaly, prominent maxilla, growth retardation, wide space teeth, if it's an untreated child. Now, what they're saying is even with dietary treatments, unfortunately, some degree of cognitive impairment is seen. And it can vary from gross impairment to changes detected on cognitive tests. Now, cerebral white matter changes seen in older infants may reflect a combination of late diagnosis and dietary indiscretion. So basically, if the diet is not being followed strictly, you will get cerebral white matter changes. But mainly, as I said, I was also a bit confused with that. But yeah, dietary treatment you would have thought would help. It would help, but it's not guaranteed. Even with dietary treatment, some degree of cognitive impairment is seen. And even with that, it can vary, from severe to mild. Diagnosis requires raised phenylalanine levels, increased phenylalanine metabolites. I think we studied that, urinary PHE metabolites, and normal cofactor concentration. I think we remembered the metabolites was raised. That was what we remembered. Now they have asked about tyrosine, but basically plasma levels of tyrosine are difficult to measure, and they are not reliable because they have diurnal variation. It can go up and down at different time of the day. Now, while the levels are low in patient PKU, they can be normal depending on what time of the day the sample is taken, whether not the patient is being treated. So it is very unreliable. You cannot go on level of what you call the tyrosine. So tyrosine is unreliable. You have to go by urinary PHE metabolites and normal cofactor concentration. This is the main raised phenylalanine levels. Basically, that's the main thing, and raised urinary PHE metabolites. Okay. So what is happening? I just thought this is the easy way to understand. Normal people, protein from food, protein from muscles, amino acids are produced, and they produce other amino acids. Some of it is produced phenylalanine. You have phenylalanine hydroxylase, and normally tyrosine is not produced. Now, what happens here? This one don't have this hormone. So then you build up of phenylalanine. So tyrosine would actually go down, isn't it? Tyrosine would go down. So instead you are having build up of phenylalanine. That's why they said urine and all, they are having high phenylalanine levels, and that is causing the health problems. So I thought this slide explains very wonderfully, very simple way what happens. Yeah, is that good? I thought that was very healthy, very helpful.
Yes, sir.
Yeah. Now what you get, and now these keep up coming up in your AKP. This typical appearance: fair hair, blue eyes, dry skin, albinism, mental retardation, acidosis keep coming up in the exam. Pregnant women with PKU look for phenylalanine level. Sepsis can cause microcephaly of the fetus. Untreated PKU sometimes makes the child smell musty like a mouse. So remember with mouse, PKU always remember mousy smell, because the buildup of phenylalanine in their breath, urine, and sweat. So basically, phenylalanine, the accumulation of phenylalanine in the breath, urine, and sweat will make a smell of like a rat, a mousy odor, like a mouse. What is the treatment? Low phenylalanine diet. You give low protein because the protein breakdown is the main problem. You give fruits or vegetables and you give amino acids. So these are the main treatments. Okay. All right. It is autosomal recessive, so the autosomal recessive 1 in 4 will be affected child. So you can see half and half, mother and child. I thought unaffected child, if this child has got both the parents doing this that way. And again, 1 in 4 will have none of the genes. And basically 1 in 4 autosomal recessive. That's what you need to remember. This is a wonderful way of showing that. So diagnosis of classic PAKU requires raised pH levels, increased urinary pH metabolites, and normal cofactor. And I think we talked about that anyway. The depends, the diurnal variation is there. Depending on what time of day it is presented, then you will get that. Okay, so just go through this one, Tanush, if you want to.
Okay.
You can go through this
A
one.
3-year-old boy is brought unconscious to the pediatric assessment unit. He had suffered from chickenpox for 5 days with mild fever, controlled by paracetamol and aspirin, but seemed to be recovering. Today he began vomiting profusely, then became combative, later drowsy and unresponsive. On examination, he is responding to pain. His respiratory rate is 10 per minute. Heart rate is 140 per minute. And oxygen saturation at 95% on air. He is completely floppy. There is no jaundice. He has 2 centimeter hepatomegaly. And his, this is BM6 blood sugar, I think, isn't it, sir? It's 0.9
Yes.
millimoles per liter.
Yes.
Which one?
Mm.
The BM stick,
The last
0.9
part
BM
is
stick.
like,
Yeah, blood sugar. They do the blood sugar. In UK, be prepared because they will, they do BM stick all the time. Any child comes in, if you're coming with whatever, they will check if you're unwell. So that is showing what? Low sugar, isn't it? You need to have an idea what is the normal range. Okay, I think the normal range we thought in the other one, but this is low, I think.
So this is the hypoglycemia.
Hypoglycemia.
This child has hypoglycemia.
Features of Ray's syndrome. Ray's syndrome.
Yes, why Ray's
Floppy,
syndrome?
So the
and then-
child has been suffering from chickenpox, had administered paracetamol and aspirin. Aspirin is the triggering factor. And there is hepatomegaly with no jaundice.
Okay. Sure about that, yeah?
There is hypoventilation. Respiratory rate is 10. Heart rate is 140.
Feature of
Let's wait 10
yeah.
minutes. Heart rate is 140, oxygen, I think, saturation 95%, not too bad. Okay. So he's had chickenpox, he's had paracetamol, aspirin, he's recovery. Okay. So which one is the most likely?
So, can we see the question once again? How many days later it is presenting?
Yeah.
Yes.
There is a
Suffered from 5 days.
5 days.
5 days. Hyperglycemia. Okay, so the choices, please.
So he has hypoglycemia.
Hypoglycemia.
The BMC has one. The blood sugar is less than 2.4. That is hypoglycemia. Hepatic failure.
Is ultimately hepatic failure. Hypoglycemia is one of the features of hepatic failure. So you said Ray's syndrome, so that was the right thing.
Yeah. Yes.
So I don't know why you chase. See, that's why this is a very tricky thing. You see how you got the answer. You said Ray's syndrome, and you got aspirin and liver failure means what? Ray's syndrome.
Ray's
and
syndrome.
if it is Ray's syndrome, it is ultimately diagnosis of hepatic failure. Hypoglycemia is just one of the features of Ray's syndrome.
Sure. Yeah.
So be very careful. See, even with knowing it, you got struggled. So Ray's syndrome is obvious because of chicken pox and all that. And then they give the paracetamol, they give the aspirin, and sugar came down. Prudor, usually upper respiratory tract. Aspirin is independent risk factor. It will be given only to children under 12 for specific indications. Kawasaki's disease, usually they give aspirin is recommended in rheumatic fever or Kawasaki. That's where, you can give it. It's recommended. But not in this sort of thing. Okay, so I hope that helps really. This Ray's syndrome keeps coming up in the exam. By the UK exam, Ray's syndrome is common. So what is Ray's syndrome? fatty liver with encephalopathy. Okay, so children less than 15 years old treated with aminosalic acid for viral
Salicylic acid.
aminosalicylic
And
acid
salicylic.
for viral fever. So you get diffuse mitochondria. See, you will get a lot of questions on this. Take it from me. If you don't know Ray's syndrome, means you had it. They are easy peasy questions. So mortality rate is pretty high, 35% almost, 30 to 35%. So 1 in 3% with this Ray's syndrome will not make it, will die. Or at the final level, what is the mechanism? It is diffuse mitochondrial energy, and they will ask you in the. I've seen a lot of MCQs where they will play with you with these questions. Diffuse mitochondrial energy. What is happening? Chickenpox or influenza infection. You're giving salicylate. Severe several days after recovery, permanent hepatitis happens. Generalized edema, and this is altered sense of consciousness, behavioral changes. So I think cerebral edema, we know that anyway. And salicylate use, other risk for environment. So there are some urea cycle disorders, immunoaneurysm, metabolism, anything. What is the history? So child will be vomiting, agitation, lethargy, restless. Child will be very restless. The diagnosis is you get hyperammonemia. So ammonia is raised, sugar will be low, prolonged prothrombin time, and extensive fatty evacuation of liver. If you do a biopsy after the patient has died. So hyperammonemia, prolonged prothrombin time, hypoglycemia. These together with diagnosis. Treatment is glucose with fresh frozen plasma, mannitol, and mannitol decrease cerebral edema. So we know the treatment. And fulminant hepatic failure is a complication. But anyway, I think you got the main point, which is essential for exam. Glucose with FFP is the treatment. Mannitol, you don't have to give immediately, but decrease cerebral edema. Okay, so you got your stuff, yeah? Useful?
Yes, sir.
Fatty liver answer. Thank you. Course of turn, is it? Yeah, go through this. This is also interesting because you will get a lot of questions on obesity. A lot of questions. So a 12-year-old girl in clinic who plots on the 90th BMI centile. She demands to know why she's overweight. And this is the most appropriate explanation for her. So there has to be appropriate explanation for what's happening. And the explanation can be, most of the time, usually one explanation. So they're asking a few things, which one it's basically based on a paper. So one choice is that most evidence for the cause of obesity in children comes from randomized controlled trial. Okay, second is small for gestation age babies are increased risk.
Increased risk of obesity.
Now the answer correct I have put there, but anyway, go through the others. Most risk factors for obesity are not modifiable. Because I think this is a very challenging question actually. Forget this answer, we're correct and all that, but go through this. Most risk factors for obesity are not modifiable.
Obesity are not modifiable.
Okay. Medication is a common cause of obesity in children.
Obesity in children.
Okay.
White children have an
Now, white children have an increased risk of obesity compared with Hispanic, Black, South Asian, and
Black,
Native
South
African.
Asian, and Native American children.
Okay, so just think I've given one correct by chance, but actually, do you believe in that? And what do you believe are the others? Because there could be one option, but there could be multiple options as well in the same question. If you had multiple options, what else would it be?
Most risk factors for obesity are not modifiable.
This is based on a paper, actually, landmark paper. So this question is totally based on that landmark question, what you call research paper.
Are you there?
I'm here.
Yeah, now we can move.
So see, Darushi, what you feel? Any choices?
I think number 4 I would add, sir, also.
You think number 4 is answer, one of the choices?
Number 1 and the number 4. If more than one choice would be there, number 1 and number 4.
Medication is a common cause of obesity, and number 1, most evidence for the cause of obesity children comes from
no, sir. Number 4, sir.
Number
4, sir. White children have an increased
okay.
Children have an increased risk of obesity.
Okay, so that is true. Yeah.
Yes, sir. Okay. So number 5.
Yeah, that is actually, this is also one of the choices actually. So
Okay, okay,
one,
sir. Now
two,
number
three,
5
four.
and number 2, sir. So
Okay,
number
these two.
number 2 and number 5 I'm choosing.
Mm.
So number
Manushree,
one.
Manushree, any
So
choice?
I would like to go with number one.
Most evidence for
I
cause
would
obesity
like to
still
go
comes from
with number
randomized
one.
control trial. Okay, so you believe in that one. Only this one is correct. Now, this is a very interesting one, actually, very interesting. So we'll go through some of the things, and I'm sure you will get a lot of questions from this one because the information is extremely brilliant. Challenges, and because obesity is, as you know, you will get questions from that. So you have to know. Now, why this happens? Yes, small for gestational age, they have increased risk of obesity because of catch-up growth. Okay, so normally obesity is caused by higher energy intake than expenditure. Okay, and it is difficult to determine individual contribution of each risk factor for obesity, as you can, often they are sometimes they're very interdependent and you cannot measure separately. Now, many studies have reported associated with wide range of risk factors and childhood obesity, but confounding ones or even reverse casualty could explain the association. So let's see what the explanations are. 1 second. Now, one thing they're saying is role of medication in causing obesity has not been extensively studied. I don't know why you felt that. Medicine is not one of the causes for obesity. And it has not been studied. There's not enough paper on it. Okay, so that is the first thing to go down. Now, we thought about there are many randomized studies, but actually there are only very few randomized controlled trials which provide the most solid evidence providing identifying cause of obesity. And we just think obesity is because of a lot of sugars and lack of exercise, and we make it sound very simplistic because in real life, I think those who've done it know how difficult it can be to lose, try to control obesity, to lose weight. So anyway, the first is role of medication is not been studied. Very few studies identify cause of obesity. Some risk factors are not modifiable. For example, genetic variants, but most are common and modifiable. So we know what is the common cause of obesity: low physical activity, high dietary intake, sweetened drink composition, consumption, and television, alcohol levels. So these are all there. So next time if you get a choice, they might ask you these ones, and they have got a role definitely. Okay, these are definitely the roles here, but the factors which definitely make a difference. And as I said, there are actually, unlike what the choice they give, there are not many randomized controlled trials which provide solid evidence in finding cause of obesity. They just don't have enough data. And role of medication is doubtful. Just going through this one, and obesity also caused by high energy intake than expenditure. ঠিক আছে? Anyway, so now what we'll do, so I hope you see this one, small for gestation age as the increases obesity through catch-up growth that we've talked about. So this is when child experiences a period of accelerated growth velocity to compensate for a period of slowed growth until they get back to their genetic trajectory. So basically, once they are given the chance, they will try to pick up their lost growth as quickly as possible, and that is what they meant by catch-up growth. So at the end, you will see that the weight is same after maybe 1-2 years. Okay, factors that signal regulate postnatal catch-up growth may contribute to the pathogenesis underlying fetal origin hypothesis. Hispanic, Black, South Asian, Native American children have an increased risk of obesity compared with white children. Very simple thing. If you are going to think that you are in USA, New York, or wherever, you will probably, Asians are most likely to be the ones which are, which have got
Obese.
middle-aged people, they are obese. We are obese. We have more tendency to obese. So genetically, metabolic people, or and even South Asia means us really, or Native American children have increased risk of obesity. And Hispanic, Black, so we've talked about. So colored region. And as I said, this is something you will get a lot of questions on. Okay, obesity is something very hot topic. You will get a lot of questions on. Now, this one I think is the last one. I think this is the last question. Coach, so we want to go through this. Not very difficult. Just but just to give you an idea that this sort of question comes in exam. You are actually, if you have done, wards, or if you're doing intensive care, you should know blood gases, even if you're doing units. So
Sir,
just keep on.
PO2 pH is 7.26.
Yes,
7.26. That's acidic. PO2 is 12.1, and standard 14 points. Standard bicarbonate is 14.7. So, sir, there is acidosis, and PCO2 is also less.
So this seems to
So,
be both
fatty-
mixed
both
respiratory acidosis and metabolic.
respiratory acidosis and metabolic acidosis is there.
so what do you say, respiratory?
Respiratory.
It is acidosis. We know it is
Alkalosis
acidosis.
is there.
So
That is a
respiratory or
metabolic
metabolic?
acidosis is
No,
there.
no, no.
Metabolic
Sorry.
acidosis
Why you
is there.
saying metabolic?
Because the bicarbonate, the pH is acidotic, and the PCO2 level is less, sir. 3.9
Yeah. PCO2 is on the lower side, really. Okay.
on the lower side.
Bicarbonate is okay. Bicarbonate is also pretty much low. So, and the PO2
Yes, it's also on the low side, sir.
lower side.
It's a mixed picture, basically, sir. Mixed picture.
So, what is it called? So, old to 18-year-old female, depression of conscious level, arterial blood gas increase.
So,
Mixed,
probably poisoning or something.
So
Yeah,
this
to
is
18-year-old female,
metabolic
depression.
acidosis.
Yeah, metabolic acidosis.
Metabolic acidosis
This
is respiratory
metabolic
alkalosis.
acidosis is
Yeah, 7.26 is acidosis. And why is it metabolic?
acidosis.
Because the bicarbonate is low.
Because bicarbonates are also
bicarbonate is
lower.
also
So
low.
that is
Bicarbonates are
metabolic
also low.
acidosis. That's the answer.
Yeah.
That is the metabolic. And if
And probably drug induced.
yeah, because teenagers take all this stuff, no? And so which one of the following would you account for these results? No, it's saying only one.
Metabolic acidosis. So it will be metabolic.
Metabolic acidosis.
Metabolic acidosis.
Metabolic acidosis, is that what you said? Okay.
Yes, sir.
I think that makes sense, isn't it? Because you had tablets. You are right.
Yeah.
Because it was bad. It is very it's obvious because it's a teenager, 18-year-old, depression. So that is also some of the side information from the side, some hints. And then pH is 7.26. And if it is standard bicarbonate is less than 20, that is anyway it is going to be recall metabolic acidosis. How would it have been respiratory alkalosis? What would happen if it was respiratory alkalosis?
Then the PCO2 would have been high, sir.
Absolutely. And Tanushri, thanks for that, because it sounds very obvious, but in the exam, you will get one or two questions which will be based on what we do in the blood gas analysis of the lab. What it will be basically blood gas analysis result for a baby who's ventilated, and you comment on it. So so there you have to know about this. Some basic things about how to approach these different blood gas scenarios. Okay. Yeah.
The practical scenarios are more difficult, sir.
Yeah, but even then, I think as long as we have a broad idea about which one is metabolic acidosis, which one is respiratory acidosis, but if they want to have a some basic ideas, that's what I think they will be doing really. So anyway, so it has metabolic acidosis with the effort and respiratory compensation as reflected by elevated PO2 and reduced PCO2. This could be due to positioning or conditions such as diabetic ketoacidosis. It could be poisoning also. Vomiting could cause a metabolic alkalosis. So today, here we are. Okay. So today's session,
yes, sir.
I think we are 9:48, around 50. We started on time. So I think, any thoughts, Gustav, Tanushri, about metabolic? What you thought? We should be studying, I guess. So
no, sir. I always find metabolic very, very difficult. Both I find metabolic very difficult, sir. Metabolic acid-base disorder. I found it difficult for the FOP TAS, both cases.
Okay. But I think
so it was helpful, sir.
This is helpful. I think Urmila, whatever we will be doing some sessions in our course on metabolic acidosis, because I remember I went through the question papers recently, and a lot of the mock exam answers the questions and all. and increasingly you will have to face. There are some question answers which you cannot miss. Some of the scenarios nowadays they are giving is like ventilation. A child is on ventilation, and you begin the
Yes,
blood
sir.
gas reports, isn't it? That comes up in exam
Is a
nowadays.
data interpretation regarding
Yes, data
ventilation
interpretation.
reports and
Yes,
yeah,
data
yeah.
interpretation. So you know the child is on ventilation, and this is the blood gas report. So what will you do? How will you manage? What will you do? Will you raise the
Peep or the
PEEP or
PEP,
PEEP or
that
all?
PEP
So
or the respiratory
absolutely,
rate or anything.
other rates. So
Mm.
you need to have a basic idea. And so and this is
Okay,
absolutely
sir.
important. No? If you're a registrar, senior registrar, you need to know these things. And it is very much understanding the concept, not just quick, some sort of quick answer. So, and obviously you get the scenarios like in pediatric intensive care, we get these scenarios all the time, where someone has overdosed himself or herself, or mainly teenagers nowadays
Yes.
with all this problem. So you need to
Okay.
have a very good understanding of acid-base analysis, where in the course now we will be dealing in that in detail. And this time also
Okay, sir.
for the AKP, what happens nowadays is lot of pictures. Okay, so you need to have like good idea about EEG. So all sort of EEGs, you should be able to look at a glance and say these are the main types of EEGs. One is the burst pattern. One is what we call the burst pattern. One
Three
is
second
called
spike.
3 second spike. So these should be at the top
Hypsarrhythmia.
of it.
Hips rhythmia.
Gives rhythmia.
Hip.
Then sometimes
Mm.
in encephalopathy you get the slow wave sort of, yeah, very
Mm.
something like a overall like a very slow sort of spread. So these hypsarrhythmia, this 3-in-1 spike, and all the other ones we talked about. So these have to be on your head so that you get the thing. You just have to get the answers right, that one. And a lot of these questions come on what you call skin conditions, AKP. A lot of like something similar questions like they use I've a lot of pictures on skin conditions like eczema and blisters. If you see, there's a chart on different types of blisters. You know that subepidermal blisters or what you call, different types of blisters, and you have to, this blisters also, you have to different. I'm talking of bullous, pemphigus, bulla, yeah, pemphigoid. Are you getting me there? Yeah. So
Yes.
lot of questions come on these things, and depending on the treatment, also at which level the lesion is. To get a bulla or there's a pemphigus, there are different levels, isn't it? So you need to have a good idea of the not only eczema, but also the as I said, the blister type of blisters conditions you get, pemphigoid, IG, pemphigoid. There's so many types. Anyway, so I think what we'll do is we'll stop for today. Now there will be a gap because I'll just stop it now because we finished really. I'll stop this and I'll stop the recording as well. Okay, stop recording. Stop.